right. Good morning, everybody. Welcome back to the webinar. Thanks for the introduction, Justin. My name is Cleve. I'm one of the urology registrars at Frequency, currently working at Red Cross, and today I'll be defending the side of the argument that we should treat these patients with total endoscopic management up front. So as Justin mentioned, we've got a young boy with a neuropathic bladder. He's got a VP shunt in, secondary to meningeal. He is in a wheelchair. Sorry, can everybody hear me? Okay, can everybody mute their mics, please? Thank you. So he's in a wheelchair, and he's currently being managed conservatively so far. But he now has clinical features and imaging features which show failure. He's got bilateral necrosis, whether this is obstruction or secondary reflux, we're not 100% sure. He's got a renal function which is lower limit starting to deteriorate below 90. And then his UDS is showing a smaller than normal bladder capacity with quite high pressures of 32. So definitely high enough to probably contribute to this deterioration in renal function. So the question of this morning's debate is, should we offer this 6-year-old boy upfront Ileocystoplasty bladder augment, or should we go with Botox and Deflux endoscopic management? So I'm going to be discussing why we should probably first offer this child Deflux, Botox, pardon me. So starting with the evidence and the guidelines, and the current EAU guidelines 2021, they do recommend, there's strong evidence to recommend Botox in this setting. They said it's an alternative and less invasive, I think that's the key word there, less invasive option in these children who are refractory to more conservative measures before offering them a bladder augment. Just a little bit about Botox. So obviously it comes from the bacterium Clostridium. This was first discovered by a Belgian bacteriologist late in the 19th century, and 17 serotypes were described. Type A is the one used in urology. There are 2 forms of A, but they have comparable outcomes between the 2 of them, so it doesn't really matter which of the 2. The molecule itself is a protein with 2 chains, a light chain and a heavy chain, held together by a disulfide bond. And quite important to know how this thing works, and because and why it's not only there for you sort of in the bladder. So what it does and how it prevents bladder contractions, overcontractions, or uninhibited contractions, it inhibits vesicular neurotransmitter release at the neuromuscular junction and neuroglandular junction. There are 2 cell surface receptors that Botox attaches to, as the gangliosides and this SV2 family of proteins. And as you can see in the diagram here, that it's the heavy chain of the Botox which first binds to the SV2 on the surface of the nerve terminal. That's followed by endocytosis and internalization of the toxin. And then once it translocates to inside, that heavy chain is cleaved off, and we'll only have the light chain left, which is the active moiety of Botox. What that light chain does is then it cleaves the SNAP25 protein, which is a protein with function that is essential to the binding of vesicles to the cell membrane, and that inhibits neurotransmitter release. So what are some of the effects that we'd expect, especially on a UDS from Botox? We'd expect to improve patients' bladder capacity and decrease their intravesical pressure, as well as improving compliance of the bladder. This is one of the earlier studies which is looking at effects of Botox and whether we can use it in patients who have failed conservative therapy. This was done in 2003. So essentially what I said here, looking at kids with hyperreflexive neuropathic bladders who are no longer coping on just conservative management. They looked at 20 kids with very high leak point pressures, gave Botox at a dose of about 12 units per kg, and they followed these kids up at 1, 3, and 6 months after injection with UDS measurements thereafter. This is one of the kids, a 7-year-old boy, and this is his UDS parameters before and 4 weeks after Botox. And what they looked at here was reflexive volume. So it's the volume in the bladder when the first uninhibited contraction occurs. As you can see in the top UDS parameter, his bladder was full to about only 44 moles before he was getting uninhibited contractions. And then 4 weeks after Botox, on repeat UDS, they could fill his bladder up to almost 200 moles before any uninhibited contractions were encountered. If you look at the graph here, the green is sort of the standard parameters before Botox injection, and then the others are the monthly follow-ups. So you can see in all of them, especially reflex volume and bladder capacity, there was improvement seen up to 6 months afterwards. Quite significant improvement. The only one is initially there was the true set pressure improvement, But after 6 months, as you can see in the graph, it returned back to baseline. So they conclude that Botox is very valuable in the management of neuropathic bladders, and that the effect lasts for about 6 months before a repeat injection is needed. If you look at this study by Zeno and colleagues, this was I think in 2011, they wanted to compare single dose versus repeat injection of Botox. So in their patient population had 28 kids who also failed conservative management. And these kids were all then offered Botox as a secondary or second step. The mean follow-up was about 4 years. And what they did was they divided these kids into two groups. 14, group one had single injection over that time, and the other group had repeat injections ranging from sort of 1 to I think 4. In the single group injection, they only received 1 injection and were followed up continuously. 5 of the 12 patients showed the following: increased reflex volume, decreased pressure, increased compliance, and decreased liquid pressure. If you look at the group that had repeated injections, 13 of the 14 had UDS parameters that were similar to those obtained in the first group. So it showed very good response here again. And they said, concluded that Botox is a safe alternative in the treatment of diffuse hyperactivity. And the effect lasted in their study for about 12 months. And the urodynamic response was unchanged even after repeating several injections. You can still achieve the same outcome. But what about the upper tract? So studies do show that improvement in bladder function in these neuropathic bladders can lead to resolution of secondary reflux. The study by I can't pronounce that name, pardon me, was done in 2006 as a prospective study involving 26 kids. And what they wanted to look at was the effects of Botox on reflux, as well as patients' clinical symptoms like incontinence. And they looked at UDS and MCUGs before starting their study and 4 months after patients had received their injection. And what they found was, of their patient population of 26, 15 of those kids had different grades of reflux. And of that 15, 11 showed an improvement in their grade of reflux after Botox. This is an example of 2 of the kids, A and B's, before and after, and seniors before and after. And you can see just with Botox alone, there's quite a significant improvement in their reflux. So what about what other alternatives do we have for Botox, especially for the reflux setting, for the upper tract setting? So obviously the most commonly known and used one that we use is Deflux. It's a gel consisting of these 2 sugar-based molecules. And the important part of this is that they're both produced and found naturally within the body, meaning that there aren't any significant allergic sort of reactions when using these agents. There are multiple studies available which showed good Deflux long-term efficacy, but that's all been in the setting of primary reflux. This is one of them. This is one of the earlier ones, 2001, basically to look at the long-term effect of Botox and safety. So they looked at kids who had reflux grade 3 or higher and who had been presenting with UTIs. And those children who had persistent reflux after giving an injection of Deflux were then given up to 2 more implantations. So the key word or the important thing about this study was that part of the exclusion criteria was neurogenic bladders. So any neuropathic bladder, or these were all primary reflux causes. And looking at the graph alone, you can see from even grade 3, grade 4, grade 5 reflux, there was quite an excellent response. Of the 228 patients, only I think it was 70 odd that needed a repeat injection. And after 5 years of follow-up on the last MCG, 81% had no dilating reflux. So very good results here, showing that Deflux alone is quite good for reflux, especially in the primary reflux. But how does Deflux hold up in a secondary reflux setting? So this study by Pollock, Twitch, and colleagues was to look at sort of that and how it responds there. A small study that looked at only 12 patients in total. Initially, what they did was they looked at the short-term, long-term, and what they found was that short-term, you can achieve some success by giving Deflux. About 50% of these patients had a good response to the reflux. But after long-term, after a single injection of Deflux, a median about 4.5 years, that dropped to about a quarter of the cohort of patients who were free of reflux and then would require surgery. So they concluded that long-term follow-up of these patients showed that Deflux in the setting of secondary reflux wasn't great. As we mentioned now, in this whole study, the cause of the secondary reflux was never addressed prior to giving these kids Deflux. And there aren't any studies available which show the combined effect of both Deflux and Botox in a secondary reflux setting. Another issue is they don't talk much about the technique which was used for administering the Deflux. As you know, we've got the sting technique, which involves injection at the 6 o'clock position, and the idea is to create a crescent-shaped mound. And then we got the HIT technique, hydrodistension, about 4 millimeters into submucosa and the ureter. And the idea is to get a volcano-shaped mound. And this is important because of physics. If you look at Poiseuille's equation, when using the HIT technique, it produces a double-sloped plateau that increases length and generates more resistance to the reflux flow. So whether or not, if all of these studies included HIT, it would show a difference. It's unlikely. I think it's just important that to know which setting to use it in. This is just a systematic review showing all the studies comparing sting and HIT. And if you look at this forest plot over here, almost all of them favor HIT for the sort of long-term outcomes for patients with reflux. So if you are going to be using Deflux in a secondary reflux setting in a patient that's getting UTIs, it's definitely better to use the HIT technique. If we go back to the Botox component, what sort of alternatives or what sort of new developments are there in administering Botox, which can help patients further in a less invasive manner? There's electromotive drug administration. So it's already been used in urology for interstitial cystitis and for bladder cancers, but this is a minimally invasive treatment. It involves an electrode catheter, which is being used to administer targeted high concentration of drug, i.e. Botox, to the urothelial tissue. This is done via current, which combines the effect of ionotrophoresis and electrophoresis. So these ionized molecules are actively transported to the affected area of the body. This study done in 2018 wanted to look at the long-term efficacy and success rate of this EMDA Botox administration technique, again in neuropathic myelomeningocele patients who had been failing conservative therapy. 24 patients involved in the study, and these kids were followed up over 6 years. The electrode bladder catheter gave 10 units again of a kg of Botox. And importantly, it was inserted without any anesthesia and done on an outpatient basis. If you look at the follow-ups at 1, 2, 3, 5, and 6 years, you can see after the first year, with just a single dose, 75% of the patients were completely dry between CIC. And after 6 years of just having a single dose, still 30% of these kids were completely dry between CIC. So that's without any repeat EMDA given. Also, the mean diffusive pressures decreased significantly, and the maximum systemic capacity also increased. They concluded that this technique is feasible, safe, it's reproducible, it's cost-effective, it lasts long, and it's a pain-free method which can be done on an outpatient basis with long-term duration of effects, given without anesthesia and patients not needing a cystoscopy. It's a novel delivery system, and it results in considerable improvement in urinary incontinence as well as UDS parameters. We've spoken quite a bit so far about the Botox and the Deflux and that sort of endoscopic side. So what about the bladder augment side in this 6-year-old child with a failing conservative management? So EAU guidelines, if you zoom in here, states that if any form of deterioration in the upper tract or failure, you do go to Botox first. And only once that's not working, you would go on to something more invasive, such as an augmentation procedure. And the reason for that is because augmentation procedures are not entirely safe. They have both short and long-term complications. Complications such as bladder calculi, metabolic derangements, bladder perforation, B12 deficiency, and malignancy. If you look at bladder calculi, studies show that about 11 to 52% of these patients will develop bladder calculi after an augment, with the majority occurring sort of in the first year. Even if you look at the upper tract and bladder stones, you'd expect almost all the bladder stones to be infectious based, but some studies have shown that up to 30 of these have been found to be non-infection stones. And even after treating stones, about 30% of patients will have stone recurrence within 2 years. Metabolic derangements, so we know when using Ileum, patients develop a hyperchloremic, hypokalemic metabolic acidosis, and that's due to the loss of bicarbonate potassium. What in our adult population, what this does is it leads to osteomalacia in adulthood and osteoporosis. But in a child setting, studies have shown that this, especially when used earlier, will lead to increased risk of delayed linear growth in kids. So timing of when to do the augment is extremely important. One of the more severe ones is bladder perforation. It's a morbid and catastrophic complication with reported rates ranging from between 6 and 13%. The study by Metcalf and colleagues looked at 500 of their augments, which they did in their patient population. They found 46 of their kids underwent a spontaneous perforation, so nearly 10%. And if you divide it and you look at when they occurred, it's not really consistent, with a third of their perforations occurring within 2 years, another third between 2 and 6 years, and another third after 6 years. So it can sort of occur whenever. And the perforation occurs due to increased pressure in the bladder, either from overdistension, from poor compliance, from chronic infection, traumatic aspiration, or necrosis of the bowel segment. They also mentioned that it's very catastrophic in the sense that it leads to infection of the VP shunt, patients get meningitis, CNS complications. So it's quite a severe complication which can occur. The B12 deficiency, kids present with megaloblastic anemia, GI symptoms, and irreversible, sometimes neurological symptoms, especially peripheral neuropathy and seizures. As we said, well, it happens obviously if you use larger segments of ileum, they say greater than 45 centimeters. But the key thing here is you think, and normally patients get followed up 5 years or so, and then you follow up less frequently. But this complication only occurs, most highest risk is about 5 years post-op. So it's something you always have to keep in the back of your mind, and something that a lot of people will probably forget after seeing someone for 5 years. And then the last of the complications is malignancy. This was a systematic review done in France. They looked at 57 articles of malignancy of the bladder augment. They found the incidence could be as high as up to 5.5% in some of the articles which they looked at. The mean latency period was about 19 years between surgery and onset of malignancy, with the majority of the tumors occurring at the site of the intraurinary anastomosis. The most common malignancy found was an adenocarcinoma, and the symptoms diagnosed were similar to what our bladder cancer patients present: hematuria, recurrent UTI, acute renal failure. The study by Kokrowski and colleagues was basically just to see how to follow these patients up, and they said there's no clear guidelines on how to screen or follow up these patients for malignancy or actually any of these other complications. They say annual cystoscopy is not financially feasible. They've actually compared it to giving Botox, and it works out to way more expensive to follow up these patients. They said cytology is not helpful, and there's not enough evidence for fluorescent insight to hybridization and PCR. So I'm going to hand over to Sifiso to continue for now.
Thank you, Cleve, for an excellent introduction. And I'm not sure that patient or person is smiling in the last picture there because of the Botox.
It's just good Botox.
Morning, everyone. May someone please confirm that, you can see my slides and everyone can hear me?
We can see and hear you, Sifiso.
Okay. Okay, my name is Sifiso Msibi. I'm a urology registrar in KZN, and currently I'm rotating in Devon. So I'll be involved in today's debate, as Cleve has mentioned his points, and then my points will be for ileocystoplasty. I won't go through the slides because Cleve have already went through it, but I'm here today to convince you that this patient, he should have an ileocystoplasty. Just to touch base on bladder augmentation, it was firstly introduced in humans by Michalix in 1889, and the intestinal segments gained popularity in the mid-1950s. And the ilex segment have been used increasingly to enhance bladder capacity, and the compliance of ileum was shown that it is greater than the colon. It is usually taken about 25 to 40 centimeters from the ileocecal valve to reduce the risk of metabolic abnormalities. And to gain the bladder capacity or enough bladder capacity, you can use the reconfiguration. Is usually performed using the Goodwin cup patch technique, of which is like a U shape, as you can appreciate on the right side of my screen. So the goals of management in this group of patients, we have to remind ourselves that we need to protect the upper tracts. We need to avoid infections in these patients. And most importantly, we need to attain the social urinary continence and as well to facilitate the sexual function. So, I mean, how does ileocystoplasty help maintaining these goals? It helps by creating a good compliance, a high capacity, and a low pressure reservoir. So what are the indications for ileocystoplasty? Well, it is a small bladder capacity with a poor compliance, a patient who had a failed conservative management, and the Botox intravesical therapy treatment. It is contraindicated, however, in patients who have inflammatory bowel disease, like a Crohn's disease, congenital bowel anomalies, radiotherapy-induced enteritis, and conditions resulting in short bowel and malignant bladder disease as well. For my next few slides, I will look at the evidence for ileocystoplasty. So I'll look at the urodynamic outcome, show about what they say about the continence and the resolution of the vesicular reflux, as well as the quality of life. So this is a study that was done by Lizette. So he did a systemic review looking at the long-term effects and complication rates of bladder augmentation in patients with the neurogenic dysfunction. So he looked at 20 studies. He had like 511 patients. So he looked at the following 3 key points: the bladder capacity. It was shown that the average preoperative bladder capacity was 169 mils, and the average post-operatively was 559. And then the storage pressures, was shown to be less, about 90 centimeters of water post-operatively compared to the initial 65 centimeters of water. And also he also looked at the detrusor overactivity. So 77 patients initially had, and only 18% of this patient complained of overactive bladder afterwards. One can ask, are these findings transient? I mean, how about long-term effects? So, I mean, Pratik et al. Answered that question. So he looked at the long-term effects, and then he looked at the minimum 10-year follow-up. So what he found was that he looked at the maximum systemic capacity, and the capacity was initially 229 pre-op, which confirms the previous slide that there is an improvement with ileocystoplasty. So it went up to 621 mils in a 1-year follow-up of surgery. And then after that, I mean, he followed up these patients after 10 years, and it was still adequate capacity. After 10 years, it was about 494 mils in that period of time. And he also looked at the maximum detrusor pressure, of which it was decreased preoperatively. The decrease from a preoperative from 81 to 41 centimeters of water in a 1-year follow-up. And then he found that it was still safe even after 10 years. It was 28 centimeters of water. And then these findings are clinically and statistically significant. In terms of continence, Makers et al. Look at the long-term urodynamic follow-up of bladder augmentation for neurogenic bladder. So what is interesting is that 90% of patients had a good continence, and then out of that 90%, only 8 needed a low dose of oxybutynin post-operatively to maintain a continence consistency. So in terms of the resolution of hydronephrosis and the VUR, Tema and colleagues look at the the resolution rate after ileocystoplasty. So they found that the overall VUR resolved in about 67% of patients, but they subdivide these patients into low grade and high grade. What is interesting here is that the low grade, about 90% had the resolution, and the resolution was short about 3 to 6 months. And then the high grade group, the high grade resolved in 53% of patients, and the resolution time was about 6 to 12 months. And what is nice with the ileocystoplasty is that you can also do a reimplant in the same setting. So he concluded that Tema et al. They concluded that the high grade VUR can benefit from the ileocystoplasty concurrently with the urethral reimplantation in the same setting. And further to add into that, Morokia et al. Did also a study looking at the management of vesicourethral reflux secondary to neurogenic bladder. So they had patients who had a high grade, and then they subclassified this patient into patient required urethral reimplantation with the bladder augmentation and other patients without augmentation. What is interesting is that the reflux did not recur in patients who had the urethral reimplantation with bladder augmentation. And it was, it recurred in 20.4% of the cases of patients without bladder augmentation. And this, is still echo the same sentiment that the reimplantation should occur concurrently with the augmentation for higher grade refluxes. Cleve mentioned, many are positive about Botox, but I didn't hear or see any slides commenting about the quality of life for these patients. And Unquintel looked at the impact on the quality of life of patients with the spinal cord injury. So he used the Cleve 30 questionnaire, as you can see the assessment overview on the right side of the slide of the presentation. So the Cleve 30 questionnaire is known to assess the bladder overactivity and incontinence. So he found that patients who underwent the ileocystoplasty or the augmentation cystoplasty had a better self-perceived quality of life with a less urinary incontinence episode. Again, it sounds like ileocystoplasty is an aggressive form of management comparing to the endoscopic therapy, as Cleve as well as mentioned that. However, there are other minimal options that one can also choose. They also show that they have a durable perioperative and a good urodynamic outcomes. So one can also opt for the patients for an open or laparoscopic. Open, you can also do it an extraperitoneal approach or intraperitoneal approach. So Lina and colleagues did a comparison between the extraperitoneal and intraperitoneal approach. So they did a retrospective chart review, and then what they found was that the extraperitoneal group had a good perioperative outcome. They had a shorter operative time, hospital stay, as well as a shorter time to return to bowel function. The conclusion was that the extraperitoneal technique provides an equal effective method of bladder augmentation to the standard technique with easier and earlier post-operative recovery. In terms of laparoscopic option, the first laparoscopic ileocystoplasty was performed by Gill et al. So he did in combination with extracorporeal bowel work. And 2 years later, Elliott described the first just a pure laparoscopic procedure, and it has been performed at high centers. And the report today showed that the laparoscopic augmentation ileocystoplasty is safe procedure, it's technically feasible, and with favorable urodynamic outcomes. So what is nice with the ileocystoplasty is that it is a versatile procedure, and one can have other adjunctive surgeries that can be offered at the same setting. I've already mentioned the diuretic reimplants, as the other option would be the catheterizable channel, so in the form of either metrophenol, tapered ileum, and appendicovesicectomy. And they are indicated for patients who have difficulties with ureteral catheterization, individual who uses wheelchair, like our patient, and obesity. And the outcome are very good in terms of continence as well. The other options will be like to do a bladder outlet procedures, but you can do them as indicated. But in terms of complications, it sounds like complications are more morbid, but I mean, if you look at the literature, they're actually, I mean, not bad as they sound. So, I mean, in terms of urinary tract infections, it has been shown that patients who had an ileocystoplasty have asymptomatic bacteriuria at the rate of 45 to 100%. And however, the symptomatic incidence was much lower, it's about 4 to 43%. And in terms of the bladder calculi, it has a rate about 3 to 52%, and it has been shown that 69% of bladder calculi are infectious. And the risk factors will include the excess mucus production, incomplete bladder emptying, and patients who are not compliant with the CIC or bladder irrigation. And the treatment option will include endoscopic or open procedures. So studies have shown that the bladder irrigation with the normal saline and gentamicin can decrease the bladder calculi formation, and that is at a higher volume of irrigation had a better effect. So in terms of metabolic disturbances, the commonest one that you might encounter in an ileocystoplasty, of course, would be hyperchloremic metabolic acidosis and vitamin B12. But however, the contributing factors will be the shortened bowel length, malabsorption, diarrhea, and dehydration. However, there are, the hyperchloremic metabolic acidosis, you can also have treatment. One can use the potassium citrate or sodium bicarbonate. And the vitamin B12 deficiency can occur when the terminal ileum is used for ileocystoplasty. However, the risk is generally low since most of ileocystoplasties, they preserve part of the terminal ileum. And the bladder perforation, spontaneous bladder perforation is one of the most morbid complications following cystoplasty. It accounts about 8.6%, but it has been shown that catheterizable abdominal stomas are at a lower risk for perforations. And the management approach will be exploratory laparotomy and the closure of the perforation. And our patient also has a shunt. So, I mean, there are studies that they did looking at the shunt infection and obstruction. So initially, the initial report by Matthew et al. Showed that the shunt infection was about 20%. So, but he had like a small group of patients, so 4 out of 20. But the recent studies, I mean, the incidence was much lower. It was about one patient over 55 patients. So therefore, the presence of a shunt should not preclude a bladder augmentation. In terms of bladder cancer, the overall incidence among patients who have undergone bladder cancer is about 1.2 to 4.6. It is unclear whether the enterocystoplasty is an independent risk factor. However, the proposed mechanisms are the urine stasis, urine acidity, the chronic infection, the bladder calculi, chronic irritation, and interaction between epithelial. As Cleve has mentioned, that the most commonest one would be adenocarcinoma followed by a transient cell carcinoma. In terms of following up these patients, EAU recommends that you need to do like a physical examination, an ultrasound to look to check for the upper tract deterioration, blood gas to check for pH and the base excess, and you need to do bloods to check for the renal function and vitamin B12. The urodynamic studies, you can do them if there is an upper tract dilatation or incontinence after the operation has not improved. The endoscopic evaluation for bladder cancers can be done after 15 years after an ileocystoplasty, and the real values of annual cystoplasty evaluation has not been proven by any studies. So, I mean, the studies have shown that the ileocystoplasty has a good functional outcome, with the majority of patients experiencing an improvement in bladder capacity, compliance, and continence, while keeping the renal function stable, and is associated with an improvement in patient-reported quality of life. So I think, I mean, to conclude, this patient, I think he will benefit definitely from the ileocystoplasty. I thank you.
Thank you, Spe. So a very compelling argument there. What I'm going to do, so long, both presenters have prepared a rebuttal. I'm going to put up a poll for those that are ready to nail their colors to a mask and vote in one direction. You can, or you can wait till the end of the rebuttal. Over to you, Cleve.
Right, just check here. Right, can everybody hear me still? I'm not sure.
Loud and clear.
Okay, great. Thanks, Safisa, for that excellent talk. Just want to conclude, just got a few more slides. When looking at Botox, this is a study came out just over a month ago, pardon me. Was a systematic review from China, and they looked at about 16 articles looking specifically at the effects of Botox in kids with neuropathic bladders. What they looked at was clinical parameters, UDS parameters, and side effects. And looking at the clinical parameters and how patients complain and possibly quality of life, urinary incontinence was the most commonly reported symptom. Of those 16 studies, 13 showed improvement in incontinence at a rate of around 54 to 100%. With regards to reflux, was the second most common symptom or sign, and 6 of the studies had patients with secondary reflux, with improvement reported in 5 at good rates as well, 73 to 100. We've already touched on the UDS parameters, with most studies showing improvement in detrusor pressure, quite significant improvement in bladder capacity, 14 studies showing improvement with ranges from 1.4 to 3.6 compared to the baseline. And a definite improvement, significant as well, in bladder compliance in all the studies, with pronounced effect coming only after 3 months. We know that also UDS is Botox can be repeated, and these parameters are reproducible on further UDSs. And then looking at the safety and side effects, they concluded that Botox injections are safe. Only 6 of those studies mentioned any adverse effects. The most common adverse effect was temporary hematuria, temporary is the keyword there. And then post-injection UTI range from 2 to 14% in 5 of the studies, with an even lower rate of symptomatic UTI. So in conclusion from my side, intravesical Botox injections improve both clinical symptoms as well as the UDS parameters in children who have neuropathic bladders which are refractory to conservative management. There are currently no studies involving both Botox and Deflux, which in theory would probably further downgrade secondary reflux, although Botox alone does this very well. Adjuncts to Botox becoming available, like we mentioned, that the electromotive drug administration. These offer the potential for outpatient management of neuropathic bladder, avoiding a general anesthetic altogether. And then, especially the last point, your major reconstructive surgery like a cystoplasty should be delayed for as long as safely possible, so as to avoid significant morbidity and future adverse events, including malignancy. That's it from my side. Thank you.
So thank you, Cleve. I mean, looking at the patient that we have a patient, a 6-year-old, the patient that's using a wheelchair. I think practically, I mean, we all agree that this patient can benefit in one operation, looking at his age. And to do the urodynamics in a 6-year-old in a wheelchair, I'm not sure if, I mean, Cliff can say that it is safe to do that. But however, as Cliff has mentioned, that the Botox has been shown to produce an acceptable urodynamic outcomes with a decreased maximum detrusor pressure and increase in cystometric capacity and your improved compliance. However, the perceived efficacy of Botox has not proved to produce a desired outcome in a low or non-compliant bladder. As the mean interval between your injections ranges between 6 to 9 months. And it has been shown that the mean interval, I mean, it has been shown that there are associated increasing frequency after each and every injection. And further, that will result or predispose the patient to the iatrogenic urethral strictures. And there are no studies in literature that that I've looked at that indicate whether injection should be repeated at a pre-established regular intervals, or do you need to consider the clinical picture or the urodynamic results, and that can appear after an acceptable response. And I mean, so I don't know if you were gonna follow up this patient based on their clinical picture if the patient comes with an incontinence, or are you gonna do the urodynamic studies looking at the 6 to 9 months? So the patient needs to come for urodynamic at least twice a year. And I looked at the quality of life of this patient who had a Botox intravesical therapy. And it has been shown that Botox injection was associated with the urine leakage as soon as the effectiveness wears out, and the patients were at higher risk of incontinence between the active treatments, making it difficult for a treating doctor to plan for the next injection on time without any risk of urine leakage between 2 injections. And the treatment dependency, and due to the periodic need of the Botox re-injection, can be a limiting factor for a success of adherence of patients. So this study, I mean, confirmed that the quality of life was found to be higher with the Ileocystoplasty compared to the Botox injections. In terms of the VUR, I mean, in the Deflux treatment has been shown to be less effective in a high-grade VUR. And as you mentioned that, I mean, as you quoted Polaquick et al., so he actually observed 75% failure rate after a median follow-up of 4.5 years with endoscopic treatment. And this raises concern about the durability of a long-term outcome in those with neurogenic bladder dysfunction. And lastly, I mean, as clinicians, we are not only treating patients, but we are also our managers of resources as per our oath. And we need to provide the best treatment for our patients at the lowest cost possible. The Botox costs about 1,650, and it carries a high financial burden for both parents and government over a lifetime horizon. And this is supported by the increased frequency, as I mentioned, of injections for each injection. And the patients, the need to be under general anesthesia and using needles and utilizing other consumables. And as opposed to augmentation, augmentation, which has the most cost-effective over a lifetime horizons. So I think that's what I have. Thank you.
Thank you to both presenters there for excellent talks. And I see that the last votes are coming in for the augmentation versus Botox poll. At this point, it looks like Botox 2/3, augmentation 1/3. But while those final votes are coming in, I thought let's open it up for questions and comments. Perhaps I'll start with a comment. There was perhaps a period of time 3 to 5 years ago where we were enthusiastic about Botox and total endoscopic management for patients with neuropathic bladder. And just the institutional trend was to try and favor the less invasive option. However, Sifiso, in our experience, we found that you're correct in that those bladders that are poorly compliant, that are really not good capacity, thick-walled, have poorer urodynamic parameters, Botox doesn't provide a good long-term solution. So we've shifted over the last 3 years or so to being more aggressive with our indications for augmentation cystoplasty and trying not to wait until the renal function is dropped and you've missed the boat, you know. So I think that's obviously an easier decision if you're seeing really poor GFRs, really bad kidneys. But in this case, the patient's kind of on a knife edge, you know, and certainly it is an operation not without complications or issues. But once the patient's had the augments and you've got them through that perioperative period, we find you can relax. If you see them in the clinic afterwards, their kidneys settle, their incontinence settles. With a Botox patient, you've got a bit of work still to do to make sure you're heading in the right direction. So those are just my musings and thoughts. I don't know if Professor Lazarus has anything further to add, or comments or questions from the participants and the...
Thank you, Justin. Can you hear me?
Yes, we can.
Thanks, Justin. Congratulations for kicking off what's a very exciting set of talks coming up, and congratulations to the two presenters for engaging quite deeply on these topics and for superb presentations. Just a question for each of you. Cleve, based on what Justin's just told you, that's been our experience, that Botox and bulking agents, total endoscopic management has a place, but it tends to be with the milder cases. Did you find any rates of conversion from a endoscopic management to requirement for cystoplasty? In other words, were there some studies where they documented that, or could you not find that?
Well, I couldn't actually find a specific study which did document that, but if you just look at that, if you look at the systematic review, which came out just over a month ago, of those 16 studies, they say that there was improvement, I think, in about 13 or 14 UDS parameters. So I would assume that in those that didn't improve, that they would obviously then move on to something more invasive like augmentation cystoplasty. I don't have the numbers though, I don't have the rates, I don't have the parameters as well, but I would say probably in about, if that would probably be about 8% of those studies, or that would then move on to something more invasive. So yeah, but I don't have any specific study which I saw.
Okay, thank you. And Sifiso, just a brief question to you.
Sorry, I also looked at that as well. I mean, I couldn't see anything, I mean, commenting about that, but what they say is that patient who had a Deflux treatment, when they go for the urethral reimplantations, there is a fibrosis of which it also carries a morbidity when you reimplant these patients.
If I can ask a question just very briefly, Sifiso, we've
Yes.
always been very cautious about offering reimplants at the same time as ileocystoplasty. I've argued that it's a secondary reflux, and therefore if you increase the capacity and reduce the pressures, the reflux should resolve. The slide you got up is very helpful to see that that's not quite true with high grades of reflux. But I just caution about using reimplant in that setting, because I think the chances of complications with the reimplant are quite a bit higher than in a native normal bladder. These bladders are thick-walled, they are trabeculated. Your chance of obstructing the ureter is quite a bit higher. Was there any details about complications related to those reimplants?
Yes, definitely there are complications, as you mentioned, that you're reimplanting a bladder that is thick, and but looking at the ileocystoplasty, I mean, looking at the ileum on its own, it's got a good compliance. So I mean, they do mention that you get complications like the obstruction. So you need to surveil this patient very closely.
Thanks.
Well, if there's no further questions or comments, it remains for me to thank both presenters and wish everyone a happy long weekend.